Hi guys, how are you guys doing? So I'm preparing for my QE1 exam. So what I'm going to do is I'm going to read aloud all those topics that I have been studying from Toronto Notes quite a while. So I'm kind of fluent with my topics right now. So I'm going to read aloud as someone suggested me to read it aloud. So it is easy for everyone to go review and study with me. So the first topic that I'm going to review is endocrinology, and from endocrinology there is not much topics that I did from Toronto Notes, but what I did is I'm going to review those ones along with you. So the first topic that I did is dyslipidemia. So for the primary dyslipidemia, definition is caused by the genetic defect in the lipid metabolism. Primary dyslipidemia, the condition is familial hypercholesterolemia, in which total cholesterol level is increased and LDL level is increased. The treatment is maximally tolerated statin as an initial dose. In addition to the second one is PCSK9, which is basically ezetimibe, or as a second line, third line for homozygotes in the portocaval shunt or LDL apheresis. The second one is familial combined hyperlipidemia, in which ApoB, lipoproteinemia, triglycerides, and LDL's level are raised, and the treatment is same statins. Polygenic familial hypercholesterolemia, LDL level is increased and it causes cardiovascular diseases, and the treatment is same statins. Hereditary chylomicronemia, triglyceride levels is increased, and this is basically present at infancy. Basically it is hereditary, so it is present in infancy. So the treatment is basically supplements with essential fatty acid and fat soluble vitamins. Familial alpha lipoproteinemia, HDL level is low, and atherosclerosis, premature, and cerebrovascular disease. Reduce the risk of atherosclerosis with the lifestyle changes and management. Since this is familial, so this is coming from family history, and it causes premature atherosclerosis. So we will start from the lifestyle modification, and then we will start with the statins. Then is Tangier disease, which is basically HDL level is cholesterol level is decreased, and it is basically mild hypertriglyceridemia and neuropathy. Reduce the risk of atherosclerosis with a lifestyle change. Then is secondary dyslipidemia. In that I am reading side notes. Familial hypercholesterolemia and cardiovascular risk calculators. Basically, risk calculators such as Frankman and the score do not apply to the patients with a familial hypercholesterolemia. Consider all patients with a familial hypercholesterolemia as the high risk. Treatment effect: each 1 millimole per liter decreases in LDL corresponds to 20 to 25% relative risk reduction in the cardiovascular disease. Statins lower LDL by about 30 to 40%. Ezetimibe lowers LDL by about 18%, and PCSK9 inhibitors lowers LDL by about 50%. 6% rule: if the dose of statin is double, there is approximately 6% increase in the LDL lowering efficacy. For the statin follow-up, liver enzymes and the lipid profile, I'm reading the page number 5 and the sidebars. For the statin follow-up, liver enzymes and the lipid profile. Liver enzymes measured by the beginning of the treatment, then once after therapy initiated. Lipids measured annually. Order both if patients complain of jaundice and right upper quadrant pain and dark urine. CK as a baseline, and if present complaints of myalgia. Otherwise we don't do CK. We only do liver enzymes and lipid profile. Discontinue statin if CK level is more than 10, upper limit of normal, or the patient has a persistent myalgia. So on the side there is written for the screening. What we do is this is page number 5. We do screening. Screening for the man and woman should be started more than 40 years or post-menopausal woman. If the following risk factors present, screened at any age, like diabetes mellitus, cigarette smoking, COPD, hypertension, systolic BB more than 140 and diastolic more than 90. Hypertensive disease of pregnancy, obesity, BMI more than 30 kg per meter square, family history of premature cardiovascular disease or dyslipidemia. Clinical signs of hyperlipidemia is xanthelasma, xanthomas, and arcus cornealis. clinical or the radiological evidence of abdominal aortic aneurysm, and clinical evidence of atherosclerosis. Inflammatory disease is basically rheumatic arthritis, SLE, psoriatic arthritis, and ankylosing spondylitis, and inflammatory bowel disease. So all the inflammatory disease, we do that. HIV infection or high active antiretroviral therapy, basically for HIV treatment. Then is coronary kidney disease. Basically, if GFR is less than 60, it means that it is having a chronic kidney disease. So we do screening for lipidemia. Then is erectile dysfunction, high risk ethnicity, South Asian and indigenous people. Screen children and the family history of hypercholesterolemia or chylomicronemia. Components of the screening: history and physical exam, like lipid panel. What we do in the screening is basically we do lipid panel. We start from the history and physical exam, then we do lipid panel, which is including total cholesterol, LDL, HDL, triglyceride, and non-HDL cholesterol, basal glucose, and EGFR. And then we do optional is basically urine ACR, albumin creatinine ratio, and then ApoB. ApoB is basically each atherogenic particles, like very low density lipoprotein and hydrogenic and low lipid, and the lipoproteinemia A. Contains one molecule of ApoB. Serum B reflects the total number of particles and may be useful in assessing cardiovascular risk and adequacy of the treatment in high-risk patients and those with a metabolic system. Lipoprotein A levels may help stratify those at the intermediate risk. Coronary artery calcium may help stratify those at the intermediate risk. CRP, highly sensitive acute phase reactant, may be clinically useful to identify those at the higher risk of cardiovascular disease than predicted by the global risk assessment. So next is CVD risk factors, which is calculated by the Frankman risk score, and there is another risk which is Reynolds risk score. The one we use is Frankman risk score. It has 10-year risk of major cardiovascular disease, calculated gender, age, total cholesterol, HDL cholesterol, systolic BP, smoking, and all those. More than 20% is high risk, 10 to 19% is moderate risk, and then lower than 10% is basically low risk. So the next is treatment of the dyslipidemia. This table is very important. So first is primary prevention, then that comes as lower risk, intermediate risk, and higher risk. As we already discussed, like more than 20% is higher risk, less than 10% is the lower risk, intermediate is 10 to 19.9%. So in lower risk, basically less than 10%, what we do is we cannot start statin as an initial. What we do is we start with the behavior modification. So statin therapy not recommended for most low risk individuals, except like only exceptions are those where LDL is more than 5 and EPO is more than 1.45 and non-HDL is basically more than 4.2. Frankman is like 5 to 9.9 with the LDL more than 3.5 and what else? And particularly with other cardiovascular risk factors more than 50, as the proportional benefit from the statin therapy may be similar to other treated groups. So what we do is health behavior modification, smoking cessation, diet, and exercise. So smoking cessation, we start with that. And then as the diet, it is recommended all individuals adopt a healthy dietary pattern. And then it is basically exercise. It is recommended adults accumulate at least 150 minutes per week of the moderate vigorous intensity aerobic physical activity. Then comes the intermediate risk, which is basically 10 to 19%. What I remember here is the LDL value, which is very important. If this is more than 3.5 millimole and that patient has HDL more than 4.2, ApoB more than 1.2, men more than 50 and women more than 60. With one additional risk factors, now HDL, IFG, and high waist circumference, smoker, and hypertension. So IFG is basically fasting glucose, And with the presence of other risk modifiers like HSCRP, like C-reactive protein, CAC, like calcium, coronary artery calcium more than 0, and basically family history of premature coronary artery disease is more than 50. So what, and at the high risk, what we do is we definitely start with the behavior modification, like discussing with that, but we also do is we also initiate statin therapy. We start with initial treatment, and our goal is to lower the LDL more than to decrease it is from 2.2 to 2, or APO is 0.8. If it is more than that, or HDL is more 2.6 or maximally tolerated dose, like we have to decrease it less than like 2 of LDL. But if it's more than that, after giving maximum dose of statin, what we go is we add on therapy. Okay, and discuss add-on therapy with the patient, evaluate reduction in CVD risk versus cost effect with and the side effects. Add-on is basically ezetimibe on the first line, bile acid sequestration as alternative. Let's suppose that the behavior modification that is written on the side, which is basically smoking cessation, diet and exercise, as I already read. So LDL is more than 2. If this is not, right, that, then what we do is, if like LDL is still like in the range of 2 and APO is in the range of 0.8, what we do is monitor for the statin RX and response to add on lipid lowering regime and health behavior changes. And still after adding to the ezetimibe, like add-on therapy, we still response to the statin. We check response to the statin, response to the add-on therapy, and health behavior changes. So we keep on checking those ones. Then next is statin indicated conditions. This is also very important. So what happens is LDL is more than 5, that is very dangerous condition, and APO is 1.45, and non-cholesterol is more than 5.8. This is basically familial hypercholesterolemia or genetic dyslipidemia. That is basically a very like dangerous condition, and most patients with the diabetes, age more than 40, age more than 30, microvascular disease, most patients with the diabetes age more than 50, EGFR is less than 60, like chronic kidney disease, and albumin creatine ratio is more than 3. And atherosclerotic cardiovascular disease, myocardial infarction, acute coronary syndrome, stable angina, documented coronary artery disease by angiography, stroke, DIA, documented carotid disease, and peripheral artery disease, claudication, and ankle brachial index is less than 0.9. Abdominal aortic aneurysm and abdominal aorta is more than 3, or previous aneurysm surgery. So in these 3, what we do is we start discussing health behavior modification, and then also start statin therapy. Now our goal is to let the LDL level less than 2. So if this is more than 2.5 or it is more than 2, what we do is in both the thing we start with the add-on therapy. Since our goal is less than 2, so it is more than 2 and 2.5. So in the both condition, we start an add-on therapy with the patient. Evaluate reduction in the CVD risk versus cost, assess, and side effects. Then we do is what we add here. What we add is basically ezetimibe, which is as a first line in the LDL more than 2, and where LDL is more than 2.5, we add ezetimibe or PCSK9 inhibitors. Now comes where LDL is less than 1.8. There is one condition where LDL level is less than more than 1.8 but less than 2. So what we do is, or APO is more than 0.9 or HDL is more than 2.4 on the maximally tolerated statin. Then we do is discuss intensification of the therapy with the patient. Like, can we increase the dose and what we can do for that patient. Then we do intensification. Refer to the figure treatment intensification approach for the patients with the arteriosclerotic coronary vascular disease. So what we do here, we monitor behavior. What we have to monitor, as we have already read, we will monitor response to the statin regime, response to add-on lipid lowering regime, and health behavior modification. So all of those conditions where this is not meeting, so we will definitely discuss the monitoring thing. Then as we have studied, like LDL is more than 1.8, then we will see the intensification of the therapy. What is the intensification of the therapy? Here it is written down. This is basically figure 3C. And patient with atherosclerotic cardiovascular disease, what we do is, if LDL is more than 1.8 or APO is more than 0.7 or non-HDL is more than 2.4, then what we do is LDL is like 1.8 to 2.2 or LDL is more than 2.2. So if this is 1.8 to 2.2, then we consider ezetimibe and PCK9 inhibitors. But if his LDL is more than 2.2, then we consider PCK9 plus ezetimibe. Like here the compulsory dose is PCK9, but on 1.8 that first one is ezetimibe. Then if triglyceride is more than 1.5, that is basically triglyceridemia or metabolic disease syndrome, and then we consider for icosapent ethyl 2000 mg BID, icosapent ethyl. Then comes the glucose metabolism. I'm not going to read all of this, so let's go for the diabetes mellitus. Diabetes mellitus basically diagnosis of the diabetes. Fasting fasting plasma glucose is more than 7 and A1C is more than 6.5%, and 2-hour fasting plasma glucose is in a 75 gram of OGTT is more than 11.1, and fasting random is basically 11.1. So what we concluded is basically the OGTT and random plasma glucose should be more than 11.1 to be called as diabetes, and fasting should be more than 7 and A1C should be more than 6.5 for the normal individual. Then comes is basically type 1 diabetes and type 2 diabetes mellitus. Then there is a comparison. Table 6. What is usually less than 30 years of the age, that is more than 40 years of the age. And then etiology is basically autoimmune for type 1 and idiopathic monozygotic twins. In concordance is 30 to 40% is associated with the HeLa, D3, D4, and with the allele 95% type 1 and DQ and confer a risk. And type 2 is basically like Black, Hispanic, Indigenous, and Asian population. Okay, so now I'm moving on to reading the page number 10 table where the risk factors for type 1 and type 2 is written. Type 1 is basically personal history of an autoimmune disease including Graves' disease, myasthenia gravis, autoimmune thyroid disease, celiac disease, and pernicious anemia. Family history of autoimmune disease. Type 2 is basically age more than 40, schizophrenia, abdominal obesity, overweight, fatty liver, first degree relative with the diabetes mellitus, hyperglycemia, race, ethnicity, which is basically Black, Indigenous, Hispanic, Asian American, Pacific Indigenous, and history of IGT and IFG or hypertension, and dyslipidemia, medications for the second generation antipsychotic, PCOS, and history of gestational diabetes mellitus or microscopic baby. So basically any side table, no. Okay, so there is a side table on the side where on the page number 10, diabetes guideline, Canadian guideline 2018, which is basically A1C should be less than 7 for most individuals, fasting glucose should be 4 to 7, 2-hour postprandial should be 5 to 10, 5 to 8 if not if not meeting target A1C and can be safely achieved, and lipid should be LDL should be less than 2 or 50%, and blood pressure should be less than 130. And who should receive statin? Basically regardless of LDL level, clinically CVD or age more than 40 years, or microvascular complications of the diabetes more than 15-year duration, or the age more than 30 years, or variant therapy based on the 2016 Canadian Cardiovascular Society guidelines for the diagnosis and the treatment of dyslipidemia. Who should receive ACE inhibitors and herbs? Like clinically CVD, age more than 55 with an additional CV risk factors or the end organ damage like albuminuria and retinopathy, left ventricular hypertrophy, and microvascular complication. Then is the ABCDs of the diabetic care. That's very important. A1C should be less than 7, blood pressure should be less than 130 to 80, and cholesterol LDL should be less than 2. Drugs for the CVD risk reductions, exercise goal and the healthy eating, smoking cessation, screening for the complications, stress management. Then is basically treatment of the diabetes. So there is a lot of things written here. I'm just going to be directly jumping into reading that glycemic targets. One of the line here is very important. 1, 2, 3, 4. Fourth one, most intense glucose control A1C less than 6.5 may be targeted to further reduce risk of nephropathy, retinopathy, and provides this does not result in the significant increase in hypoglycemia. So you can actually decrease the A1C targets by 7.1 to 8.5% whose people whose life expectancy is limited and who has higher risk of having hypoglycemia and multiple comorbidities, extensive coronary artery disease, and the failure to achieve an A1C less than 7 despite intensified basal and bolus insulin therapy. There may be harm association with the strategy to target A1C less than 6. Then comes the diet. Nutritional therapy can reduce A1C by 1 to 2%. Recommend daily carbohydrate intake 45 to 60% of the energy, protein 15 to 20% of the energy, and fat is less than 35%. Then type 1 and type 2. Type 1 is basically carbohydrate counting is used to titrate prandial insulin dose, and then type 2 comes for the weight reduction. So then comes is basically that is basically for changing the insulin dose. So by changing the insulin dose for the type 1 we need carbohydrate counting. For the type 2 we needs to reduce the weight reduction. So we go according to the weight. Then comes the lifestyle modification. We ask the patient to do at least 150 minute per walk for the moderate to vigorous exercises. Then is medical therapy, which is basically non-insulin antihyperglycemic drugs, and then medical therapy, which is basically insulin. So I'm directly jumping into the table, which is basically table figure 7. Okay, so I'm reading that table number 7, where the anti-hyperglycemic drugs are written. So first is basically metformin, which is basically side effects are the GI and lactic acidosis, but the weight should be neutral or loss. What it causes is basically neutral and loss of the weight. And then if after 3 months, if needed to reach an individualized A1C, proceed to 2 drug combination, metformin plus sulfonylurea, where weight increases because of sulfonylurea and it is very prone to have hypoglycemia. Then it is basically metformin and thiazolidinediones, which is basically weight gain, and it causes edema, heart failure, and family history. So it is very important to look at the patients who have heart failure. We don't give thiazolidinediones. Metformin and DPP-4 inhibitors, which is basically causes the weight neutral, and major side effects is basically it's rare, very rare. That's why we prefer this one. And then is basically metformin GLP receptors. What is basically does is weight loss. If somebody is looking for a drug which causes the weight loss and is very good for it, so we'll go for GLP receptor agonist. And then versus side effects is basically GI side effects like heartburn and vomiting, nausea. And then it's basically metformin plus insulin, usually basal, and then it's basically weight is gain, and then it causes hypoglycemia. And after 3 months, if the A1C is not reached to the target, then we go for the 3 drug regime. So what we do is, let's suppose we have already did metformin plus sulfonylurea, then we can add one more, any of the drug, thiazolidinediones, DPP-4, GLP-1, and then insulin. And then adding all of these one by one, after that we will check again 3 to 6 months. If the combination therapy that includes basal insulin fails to achieve A1C, proceed to complex insulin. Then we will start for the 2 doses of insulin, like basal and the bolus, usually in combination with 1 or 2 of the non-insulin agents. Okay. On the sidebar there is written sick day management. If the patient is ill and is unable to maintain adequate fluid intake or has an acute decline in the renal function, they should hold the following medication, which is basically SADMANs: sulfonylurea, ACE inhibitors, diuretics, and direct renin inhibitors. MANs stand for metformin, herbs, NSAIDs, and SGLT2. Okay. Then next comes is, I'm directly jumping to the one on the 8 eyes of the precipitating DKA, which is written on the side: infection, ischemia, iatrogenic intoxication, insulin mace, and initial presentation, intra-abdominal process, intraoperative and perioperative stress. Then there is a written duration of the activity of the different insulins. So the very small ones are Lispro, Aspart, and Glucine, and then regular stands up from the breakfast to the mid of the lunch, and then NPH is basically stays from the breakfast to by the bedtime, and glargine stays for 24 hours. So we can titrate it according to the dose that we need. And titrating insulin dose is basically hyperglycemic reading, high AM sugar. Then what we do is increase bedtime, the one that is before that. So AM is high, then we will increase the dose of bedtime basal insulin. If the lunch is high, then we will increase the dose of AM. And then it's supper time, then we increase the dose of the lunch, and then bedtime is to increase the supper dose. Or either what we can do is we can use regular insulin. Then is Okay, acute complications, DKA versus HHS. DKA is basically usually occur in the type 1 diabetes mellitus, and it is like what is causes insulin deficiency with increased counter regulatory hormones can occur in the lack of insulin or increased stress like surgery, infection, exercise, as we have already read the 9 I's. Unopposed health, glucose production, hyperglycemia, or osmotic diuresis, dehydration, and electrolyte disturbance. Decreased sodium, fat mobilization, FFA, and ketoacidosis, metabolic acidosis. So where hyperglycemia exceeds the renal threshold for the glucose and ketone reabsorption, glucosuria and ketonuria. Total body potassium depletion, but serum potassium may be then is what's the clinical nausea, vomiting, and abdominal pain, questional respiration, acetone ordered breath, and precipitating in conditions like insulin omission, new diagnosis of diabetes, infection, amide, thyrotoxicosis, and drugs. Then what we do is serum. Then we check for the serum level where blood glucose level is increased, sodium level is decreased. For every increase in the blood glucose by 10, there is a decrease in the sodium of 3 millimole per liter. That's why when we are increasing the glucose, we have to check for the sodium levels in the DK. Normal increase in the potassium, decreased bicarbonate, bun level is increased, creatinine is increased, ketonemia, and decreased PO4 like phosphate level. Increase osmolality, corrected sodium minus current sodium like plus 0.3 into current glucose minus 5. Beware of the possible euglycemia, DKA in the pregnancy and those with use SGLT2 inhibitors. Then comes ABGs, anion gap, metabolic acidosis with a possible secondary respiratory alkalosis. If swear, vomiting, dehydration, they may be metabolic alkalosis. Positive for the glucose and ketones in the urine. And then the treatment comes. Treatment is basically we check for the ABCs because this is a emergency condition. So we go for airway, breathing and circulation as the first priority. Then we go for the monitored degree of the ketoacidosis with the anion gap, not the blood glucose. We check the anion gap, okay, or serum ketone level. Anion gap is the most important endpoint used to monitor the resolution of the metabolic acidosis. So what we do is rehydration. Rehydration is basically 500 ml per 4 hour, then 250 ml per hour, more than 4 hour, normal saline. If mild moderate deficit, 1 to 2 liter per hour, NS if severe deficit. Switch to 0.45% NaCl once euvolemia. Continuous normal saline if corrected sodium is low or rate of fall of the plasma osmolarity more than 3 milliosmol per kg per hour. Once blood glucose is more than 14, add dextrose 5 or dextrose 10 with water to maintain blood glucose of 12 to 14 millimole per liter. Then we go for insulin therapy, like critical to resolve acidosis, not hyperglycemia. Do not use with the hypokalemia until serum potassium is corrected to more than 3.3. Maintain on 0.1 per U per kg per hour insulin or infusion. Check serum glucose hourly. Potassium replacement with the insulin administration. Hypoglycemia may develop if the serum potassium less than 3.3. Give 40 milliequivalent per liter potassium replacement and hold insulin until more than 3.3 millimole per liter. When potassium 3.3 or 5 millimole per liter, add KCl 10 to 40 milliequivalent per liter to keep potassium in the range of 3.5 to 5. Bicarbonate if pH is less than 7 or if hypertension, arrhythmias or coma is present, give bicarbonate -1 in 200 if pH is less than 7. Then we give for bicarbonate. Otherwise, we never give bicarbonate. In 200 dextrose 5 over 1 hour repeated every 1 to 2 hours until pH is more than 7. Do not give if pH is more than 7.1 and give in case of high threatening hyperkalemia. Prognosis is very good until he has the patient like serious morbidity occurs from the sepsis, hypokalemia, respiratory complications, thromboembolic events, and cerebral edema while giving the fluids. Then the second comes, which is very important, HHS. It is not important that it comes after type 1 diabetes, type 2 diabetes mellitus. It can come after type 1 diabetes mellitus. We just have to look up to it. If the option is given for type 1 diabetes mellitus as a TKA, then we'll go for that. But if it's not given and the HHS is given and everything is fulfilled, the clinical criteria of HHS, then we go for HHS. Often precipitated by the sepsis, stroke, MI, CHF, renal failure, trauma, drugs, glucocorticoids, immunosuppressant, phenytoin, diuretics, and dialysis, recent surgery, and burns. Partial or the relative insulin deficiency, decreased glucose utilization in the muscle, fat, and liver while inducing hyperglucogonemia and hepatic glucose production. Presence of a small amount of insulin prevents the development of ketosis by the inhibiting lipolysis. So basically what happens is characterized by hyperglycemia, hyperosmolality, and dehydration without ketosis, more severe dehydration compared to the DKA due to more gradual onset and increased duration of the metabolic compensation, plus impaired fluid intake, which is common in bedridden and the elderly patient. So volume contraction, renal insufficiency, increased hyperglycemia, increased osmolality, shift of fluid from the neurons to the ECF, and then increase the mental obtudation and coma. So what is clinical features? What happen is onset is insidious and causes weakness, polyuria, polydipsia, history of the decreased fluid intake, and history of ingesting large amount of glucose containing fluids, dehydration, decreased level of consciousness, lethargy, confusion, comatose due to the high serum osmolality. Osmolar respiration is absent unless a patient's precipitant has also covered a metabolic acidosis. Blood glucose is basically 44.4 to 133.2. In the mild higher dehydration, maybe hyponatremia, spurious to second degree to the hyperglycemia. For every increase in the blood glucose by 10, there is a decrease in the sodium by 3. So the same it applies over there in the DK. If dehydration progress, which is called hypernatremia. Ketosis usually very absent, it's not present, and mild if starvation occurs. Increased osmolality, and then what happens is metabolic acidosis. Absence usually underlying precipitant leads to the acidosis. Negative for the ketone unless there is a starvation ketosis, and glycosuria. Same resuscitation emergency measurements as DKA, rehydration, IV fluids in 1 liter per hour normal saline. Evaluated correct serum sodium. If corrected serum sodium high or normal, switch to 0.45. So basically if the sodium is high, so we will switch to 0.45. Otherwise we will stay with the normal saline. If corrected sodium is low, then we will maintain normal saline. Serum blood glucose is basically 13.9 reaches, so we can switch to dextrose 5. Same that was written over there. So it was also an emergency, so we'll go for airway, breathing and circulation, then we go for rehydration. Then the next step here, over there on the DKA, the next step was insulin. So here the next step is basically potassium, which as we are giving normal saline, what happens is potassium level decreases or increases. So we have to check less severe potassium depletion compared to the DKA, but we still have to see, because if there is hypokalemia, that is very dangerous condition. If severe hypokalemia like less than 3.3, give 40 milliequivalent per liter potassium replacement and hold insulin until more than 3.3. When potassium is 3.3 to 5, add KCl 10 to 40% to keep potassium in the range of 3.5 to 5 milliequivalent per liter. If serum potassium is more than 5, check potassium every 2 hours. Search for the precipitating events, insulin therapy, and then achieve by monitoring plasma osmolality, adding glucose to the infusion. Once blood glucose reaches more than 14, using correct concentration in saline, switch to 0.45% normal salines. Once uremia and the urine loss of electrolytes and the osmolality, diuresis are usually hypertonic. Increase saline concentration if falling too rapidly. Mortality rates basically 12 to 17%. Studies look at this included mixed DKA and HHS. So what here is basically in the both, we start from airway, breathing and circulation. Then we start from checking the ketoacidosis in DKA, where we go for the anion gap, and then we go according to that. So the next step in the both comes as rehydration. In DKA, we check for the rehydration status. If it's mild to moderate, then we go for 500, and then after 4 hours we switch to 250. But in the HHS, there is already very severe dehydration going on, so we start from 1 liter normal saline. And then we check for the sodium level. If the sodium level is like low, then we maintain the normal saline. But if the sodium level is higher or it's normal, then we switch to 0.45% normal saline. And meanwhile, we keep on checking for the blood glucose every 1 hour. So if the blood glucose level reaches 14 or 13.9, like 13.9 to 14, then we switch to dextrose 5 or 10, whatever is needed. Then in the DKA, the step changes. Here we go for the insulin, but here we still check for the potassium level. After checking the potassium level, if we see the potassium level is more than 3.3, so what we do is we correct the potassium level by giving KCl, which is basically like up to like 10 to 40%. But if it's less than 3.3, then we give 40 milliequivalent per liter. But let's suppose if the potassium level is normal, then in DKA what we do is we give insulin, so we can prevent hyperglycemia. After that, after giving insulin, which again check glucose level hourly, and then we go for potassium replacement. If potassium level is low, normal, as I already told you, if it's 3.3 to 5, then we give 10 to 40. If it's more than 3.3, then we give, like less than 3.3, then we give 40. And in the HHS, we directly jump to potassium, and then we corrected it according to that. And then we search for the precipitating factor, and then we switch to insulin. But after that, let's suppose if in DKA, the bicarbonate level or pH level is going down, like less than 7, then we give bicarbonates. That's all about it. Now next is basically macrovascular complications. What are those? CAD, like coronary artery disease, which is basically 3 to 5 times higher. Risk of MI and ischemic stroke, which is basically 2 to 3 times higher. In the men and women is 2 to 5 times. And peripheral artery disease, which is basically 15 times higher. And screening like A1C every 3 months, BP and lipid profile every 1 to 3 years, and ECG every 3 to 5 years for high risk patient. Treatment is basically, as we have already discussed, we start from the blood pressure control, we go for the glycemic control, then we check for the LDL level, then we go for ACE and ERBs for the high risk patients, and then smoking cessation, healthy diet, physical activity, maintenance of the healthy weight goals, and for the production of the adults for the CVD who do not meet glycemic control, we add the anti-glycemic drugs like basically SGLT2 or GLP, whatever is needed. Then on the side, this is basically written laboratory testing ketones. The nitroprusside test for the ketone is basically done, and acetone, but does not detect beta hydroxybutyrate. So the ketone must most frequently in the assessed with the DKA. This has 2 clinical consequences. Be wary of the patient with a clinical picture of the DKA and the negative serum on the urine. So what we do is basically we check for the beta hydroxybutyrate instead of checking ketone levels for the ketone concentration. So the next is basically treatment. That's what is written here. So what is regular reviews? Basically assess for the glycemic control, cardiovascular and renal status, screen for the complications, eye, feet and kidney, review efficacy, side effects, safety and the ability to take current medication, reinforce and the sport healthy behavior intervention. If A1C not at the target or change in the clinical status, adjust or advance therapy. And arteriovascular disease, chronic kidney disease, heart failure or age more than 60 with the 2 cardiovascular disease, what we do is add or substitute AHA with the demonstration. So in the patient with the coronary artery disease, as we have already done, what we do is SGLT2, but still the patient wants to decrease the weight, then we add for GLP. So mostly in the heart failure and in the neuropathy, the first line is basically SGLT2, and then in the patient more than 60 with the coronary vascular disease, the first line is basically GLP. And in the side, add or a substitute according to the clinical priorities. Proven cardiovascular benefit is SGLT2 or GLP, and it causes the weight loss as well. So in the coronary vascular safety but no proven cardiovascular benefits is basically GLP. So the cardiovascular benefit is basically SGLT2 is more. And on the side is basically sulfonylurea, magnesium diets and insulin, hypoglycemia, thiazolidine has the weight gain. Then comes the microvascular complication, which is basically diabetic retinopathy. And as we have already know the clinical features, we are going for the treatment and prevention. Tight glycemic control, tight lipid control, manage hypertension, smoking cessation, ophthalmic review every 1 year from type 2 diabetes mellitus. We can start it right away. And then in the type 1 diabetes mellitus, we start after 5 years after the diagnosis of type 1 diabetes mellitus for those more than 15 years. And then interval for the follow-up should be tailored for the severity for the retinopathy. So in the retinopathy, the clinical features is basically macular edema, diffuse or the focal vascular leakage at the macula, non-proliferative microaneurysm, intraretinal hemorrhage, vascular tortuosity and vascular malformation and proliferative abnormal vessel growth. retinal capillary closure. Then comes the diabetic retinopathy, which is basically screening. What we do is ejection glomerular filtration rate, and then we also go for the urine albumin creatinine ratio. Albumin creatinine ratio is known as the albuminuria, is considered the earliest clinical factor for the diabetic retinopathy. Nephropathy. So if we're going to check for the diabetic nephropathy, what is the first step we will do is basically albumin creatinine ratio. Diagnosis required to be having elevated albumin 2 out of 3 urinary samples. So we are going to take 3 samples, 2 should be positive for albumin creatinine ratio, then we say that this is the diabetic nephropathy. 24 and if that comes, then what we do is 24 hours urine collection for the protein is a gold standard, but it's difficult to perform, inconvenient and very incorrect. So that's why first we go for albumin creatinine ratio, and let's suppose if 1 out of 3 came out positive, what we switch on to 24 hours urine collection. But if 2 came out in the albumin creatinine ratio positive, then that is basically diabetic nephropathy. Best screening program at the diagnosis of type 2 diabetes mellitus, and more than 5 after the diagnosis of type 1 diabetes mellitus for the post-pubertal patients. Treatment and prevention is basically appropriate glycemic control, appropriate blood pressure less than 130, use either ACE inhibitors or ERP to delay progression of chronic kidney disease, use SGLT2 for the nephroprotection, limit use of the nephrotoxic drugs, and dyes. Then comes the diabetic neuropathy. Then screening, what we do is basically using tuning fork test 10 gram monofilament, and then we begin screening annually at the diagnosis of type 2, and then after for the type 1 diabetes mellitus more than 5 years. Then comes the clinical features of the diabetic nephropathy. What happens in the peripheral sensory is basically paresthesia, tingling, itching, neuropathic pain, radicular pain, numbness, decreased tactile sensation, bilateral and the symmetrical, with the decreased perception of the vibration, pain, temperature, and especially true in the lower extremity, but may be present in the hands. What happens is decreased ankle reflex and distal predominant lower nerves affected first, and clinical stocking glove pattern may results in the neurogenic ulceration of the foot. Then comes the motor neuropathy, which is basically less common than the sensory neuropathy and occurs later in the disease, and delayed motor reduction and muscle weakness, atrophy may involve one never trunk basically, or more, like maybe mononeuropathy or maybe mononeuritis multiplex. And some of the motor neuropathy spontaneously resolved after 6 to 8 weeks, and reversible cranial nerves like 3, like proptosis, ophthalmoplegia, pupil sparring, and the 6th and 7th, and then with Bell's palsy, diabetic myotrophy refers to the pain, weakness, and wasting of the hip reflexes or extensors. Then comes the autonomic neuropathy, and which is basically postural hypotension, tachycardia, decreased cardiovascular disease to the Valsalva maneuver, and gastroparesis, which is very common, and alternating diarrhea and constipation, urinary retention, and erectile dysfunction. What we do is we have to do glycemic control, tight glycemic control. That is the only thing. If some patient has a neuropathic pain, the first line is basically amitriptyline. Some people mixed it with the gabapentin. That is also used, but the amitriptyline is preferred over gabapentin, but we can use it gabapentin as well. Then comes is the capsaicin cream. Gabapentin, there is another place where we can use gabapentin when a patient is having menopausal symptoms and we cannot use HRT, then we also give gabapentin as a first line over there. Foot care education, and then we also fitted stocking, tilting of the head of bed may decrease like orthostatic hypotension. That is very important. What we can do for the orthostatic hypotension is basically tilting of the head of the bed. Treat gastroparesis with a dietary modification, domiperidone, metoclopramide, erythromycin, medical and the mechanical and the surgical treatment of erectile dysfunction. Other complications basically dermatologic, bone and joint disease, cataract, and infection. So what is happening in the dermatology? There is basically tibia spots that is formed, eruptive xanthomas due to increased hyperglycemia, and in this necrobiosis libiodica diabeticorum, which is basically very rare complication. So bone or the joint disease, what happens is juvenile cheiropathy, which is basically joint stiffness of the hand and contractures of the skin. Dupuytren's contracture, and then it comes is increased fracture due to type 1 and type 2 because of the bone quality is decreased, and then is adhesive capsulitis, basically frozen shoulder. Cataracts, that's the subscapular and the senile cataract is very common because of the glycosylated lens protein. And then infection. On the side there is written, and other players in the glucose homeostasis, basically glucagon, epinephrine, cortisol, and the growth hormone. C peptide is very important. A short peptide released into the circulation when the proinsulin is cleaved into insulin. So what happens if it is increased? Then it is basically endogenous, like it is coming from inside. But if it is decreased, then it is exogenous, which is basically factitious disease. Somebody is trying to get some attention and putting on like insulin levels into the body, or like and for different purposes. So by checking the C-peptide level, we can get to know. Treatment of an acute hypoglycemic like blood glucose is less than 4 in the awake patients, able to self-treat. Eat 15 gram of the rapid acting carbohydrate, like 3 packets of the sugar dissolved in the water, 3/4 cup of the glucose, juice, and wait 15 minutes. Retest blood glucose, and then what we do is we check the step 1 to 3 if the blood glucose is more than 5. Eat next schedule. Then we have to check the next schedule of the meal. If the next schedule is in 1 hour away, then we have to give the snack of again 15 gram. If it's in within 1 hour, then we will be going with the snack, with the food. Hypoglycemia unawareness, basically patients remain asymptomatic until severe hypoglycemia is reached. Once occurs after repeated episodes of hypoglycemia, the patients develop blunt and minimal autonomic responses. Causes is basically decreased glucagon, epinephrine response, and history of the repeated hypoglycemia of low A1C. Autonomic neuropathy may not be safe to patients to drive. Suggest that the patients obtain a medic alert bracelet if at risk of hypoglycemia, especially in the hypoglycemia unawareness, and considered use of advanced monitoring system, continuous glucose monitor, flash glucose monitor. And then is basically refer to the guidelines, refer to the Diabetic Canada guidelines for the advance around diabetes and driving. So what happens in the hypoglycemia? It is very important. And that's it. Okay, hypoglycemia occurs most important in the patient with the diabetes mellitus receiving insulin and certain anti-hypoglycemic drugs like insulin secretagogues. In the patient with the diabetes mellitus, without diabetes mellitus, care must be given to distinguish hypoglycemia that occurs in the critically ill and medically patient from the hypoglycemia that presents in the individuals who are seemingly ill. Each invokes a separate diagnosis. The treatment of hypoglycemia may be also provided due to the clone of the higher diagnosis, that individuals with the insulinoma typing having fasting hypoglycemia, whereas those with the non-insulinema pancreatogenous hypoglycemic experience predominantly postprandial hypoglycemia. Causes, what could be the causes? Insulin dependent and insulin independent. Insulin dependent is basically exogenous insulin, sulfonylurea, pentamidine, autoimmune hypoglycemia, insulinoma, and non-insulinoma pancreatogenous hypoglycemia, and post-gastric bypass hypoglycemia. Then comes in the insulin independent causes, basically hepatic failure, renal failure, inanition, hormone deficiency, non-eyelid cell tumors, inborn errors of metabolism, carbohydrate metabolism, and glycogen storage disease like glycosemia, Niemann-Pick, Tay-Sachs, and alcohol and the drugs, basically quinine, indomethacin, gefloxacin, lithium ACE inhibitors, and beta-adrenergic receptor blockers. Then comes the clinical features: Whipple's triad, autonomic diseases. Whipple's triad is basically 3 things: that insulin glucose level is low, then is neuroglycopenic symptoms, which is basically having tremors, anxiety, sweating, palpitations, tachypnea, and hunger. And then if you give the glucose, there's all the symptoms resolved. Neuroglycopenic symptoms: dizziness, headache, clouding of vision, and mental dullness, fatigue, confusion, and seizures and coma. This hypoglycemia is also occur in the patient who has colon surgery and has dumping syndrome. After like 15 minutes, the patient suffered with the hypoglycemia, and then we have to counsel the patient to eat in the small diets and frequent diets, to avoid water, just like that. Investigation: depending on the history, physical exam, and available biochemical investigations, as these may provide clue for the etiology of hypoglycemia. For example, if suspecting insulin and insulin secretagogues in the patient with the diabetes, assess for the cortisol deficiency, weight loss, hyperpigmentation, hyperkalemia, consider IGF 2 mediated hypoglycemia, and GIST. Think about renal and hepatic failure in the cases of critical. When causes of the hypoglycemia is not evident, screen for the oral hypoglycemic agents like basically sulfonylurea, glinides, plasma glucose, insulin and proinsulin, C-peptide, hydroxybutyrate, and insulin antibodies. Spontaneous hypoglycemia episode of the supervised fast up to 72 hours. If hypoglycemia occurs in the postprandial state, evaluate the patient first with the mixed meal diet. Okay, then comes is correct hypoglycemia with the injection of 1 mg glucagon IV with the measurement of the plasma glucose response. Then will distinguish endogenous and exogenous hypoglycemia from other causes of hypoglycemia. Then is treatment. Treatment is basically for the tumoral hypoglycemia. So how we will check for the correct hypoglycemia? Is it from endogenous or exogenous? As I have already told you, C-peptide level is very important if it's coming from endogenous or exogenous. And then they said that correct the hypoglycemia by giving glucagon IV with the measurement of plasma glucose response. So if we are giving glucagon IV and the measurement of the plasma glucose response is good, then it means this is endogenous, and if it's not good, then it's basically exogenous. For tumoral hypoglycemia, definitive treatment requires resection of the tumor. If that is not possible, certain medications can be used such as diazoxide for the patient with insulinoma, for non-insulinoma pancreatogenous hypoglycemia, and the post-bariatric bypass hypoglycemia. As I already told you, the surgery, actually that was not the colon surgery, that was basically gastric surgery. Sorry, my mistake. Dietary changes including reduction the amount of the carbohydrate intake and the small frequent meals may be useful for the patients who do not respond to the nutritional modification or have severe symptoms. A corbos can be utilized. Treatment of hypoglycemia episode is the unconscious patient in the patient NPO. Dextrose 50 ml in the 1 to 3 minute or 1 mg glucagon subcutaneous or IM. May be needed ongoing glucose infusion in the blood glucose more than 5 ml. Once the blood glucose should be more than 5. Then comes the metabolic syndrome. Postulated syndrome related to the insulin resistance is hyperglycemia, hyperinsulinemia, hypertension, obesity, and dyslipidemia. Obesity aggravates the extent of the insulin resistance. Complications: diabetes mellitus, atherosclerosis, CAD, MI, and stroke. And women with the PCOS with increased risk of insulin resistance, hyperlipidemia, and metabolic syndrome. Not to be confused with the syndrome X, may be related to the angina pectoris and normal coronary arteries. Then there is basically metabolic syndrome, Meyer, man and woman. So in the man it's different, in the woman it's different, in different ethnicity is different. So that's why only Canada and US is basically more than 102 and more than 88 in the woman. Then comes the triglyceride, which is more than 1.7, HDL less than 1 in men and less than 1.3 in the woman. Blood pressure more than 130/80, fasting blood glucose more than 5.6. So that's it for today. I will be reading thyroid in the next my session, and this is just for my own purpose that I want to record and keep them safe for myself to read it again and again, or listen to it again and again. Meanwhile, I'm going to be doing some MCQs to refresh my knowledge and keep them safe. So if you guys want to do MCQs together, just let me know. I will do MCQs with you guys as well. And that's it for today. If you guys like it, do let me know. If not, then I'll just keep on posting for myself. Thank you so much. Have a good day, guys. Bye-bye.